Today we'll be talking about total knee arthroplasty. My name is Seth Perry and I'm joined by.
And I'm Jade.
So we've all, at this point, I would assume that everybody in here has worked with or at least seen a total knee arthroplasty. So none of this should be super new, but some of the objectives that we have today are define what a TKA is and some of the indications for receiving a knee arthroplasty. We're going to recognize precautions and contraindications to keep you from getting that procedure done, describe the surgical procedure and outline the rehab phases with exercises included, and then also summarize any key points at the end to make sure that we are all on the same page. So as far as the definitions for the surgery, it's a replacement of the knee joint, which is the articulation between the femur and the tibia. You're going to receive a prosthetic that is implanted on top of the bone itself, so it's shaved away and then they attach it to the bone surface. It's going to restore function, reduce pain with those movements. It will also, something people don't talk about a whole lot, is it will restrict a little bit of motion as well. Your natural knee, assuming it's not under any deformity, actually has a little bit better range of motion than a replacement would. But it's just important for these people at their stage of their life to be able to get pain-free ranges rather than maxing out full knee flexion. Some of the indications would just be any sort of joint breakdown in general. But as far as the procedure, like I said, it's the femoral condyles and the tibial plateau are shaved down, and then the implant is attached on top of it as a metal, plastic, or sometimes ceramic prosthesis. So for the indications, like I said, it's going to be that joint breakdown. So that can occur in many different ways, but because a knee replacement, like a hip replacement, is very largely elective, your patient subjective is going to be very important here. Factors like arthritis and rheumatoid arthritis and stuff like that are important for sure, but if the patient is the one reporting the extreme pain and inability to ambulate or do daily activities, then that's going to be one of the major identifiers for someone who might receive the surgery, alongside imaging that shows cartilage breakdown in the knee to verify all of that pain that they're experiencing is from the knee joint. But it can also be caused by some post-traumatic arthritis, and this would be an operation that you would do after other interventions have failed. So obviously after you've tried the NSAIDs or maybe even the injections in the knee, and then the therapy as well, if you're still experiencing that and you have that cartilage breakdown, then knee replacement would be your best option after that. So some of the contraindications before surgery that would just keep you from receiving the operation in general. If you have any sort of active infection in the knee, because you would never want to cut that open and have the possibility of that spreading around. If you have genu recurvatum, so if you have a hyperextension of the knee, if you have that bowing of the knee as well, you don't want to create that instability and further risk any sort of damage to the meniscus or to the knee itself. Severe obesity is going to be a major contraindication for it, because the knee has to be able to accept the load that you're placing on the joint itself, especially while walking on an incline or upstairs. Those forces can increase drastically, so you got to be aware of the amount of force placed on the prosthetic. And when it comes to a patient who is wanting to return to high impact sports or occupations, you have to ask if the prosthetic itself is going to limit them in those activities, or even if the person isn't going to be able to return to their occupation or sport in a timely manner, because they're going to have to be able to go through the whole rehab phase to be able to get back sufficiently. And then arterial insufficiency, so if you're not receiving any blood flow, any sort of nutrients or fluid circulation, you're not going to be able to get that knee replacement, because it won't be able to set properly and probably end up with some sort of infection or edema or something like that. And then you have things like a neuropathic joint. So if the nerve degeneration at the knee is so bad that they're not really having a whole lot of sensation and they've caused significant damage at the knee due to the fact that they don't have any sensation, knee replacement's not going to be a great option, because they're not going to be able to accurately and properly go through the rehab phase, not being able to sense what's going on at the joint. And then mental illness as well. Obviously obviously if someone isn't cognitive, you don't wanna put them under the stress of an operation, anesthesia, and anything like that. And also, for instance, if they're being taken care of by their family members and you send them home and they don't do their exercises because they weren't cognitive even in the moment they got the replacement, they're never gonna stick to that rehab, and it's gonna most likely end up in a manipulation or maybe even worse. So some of the precautions before and after surgery. The pre-surgery precautions, I mean, to be honest, these are kind of standard even if you weren't receiving surgery, so it may kind of be hard to get some patients to stick to a regimen like this, but you wanna make sure that their blood pressure is under control and they're managing their diabetes, not letting their blood sugar get too high or anything like that. And then obviously if you get them to stop smoking, that'd be the most beneficial just for that nutrients in the blood flow and just to decrease any cardiovascular risks post-surgery. And then for the post-surgery precautions, you want to avoid the high impact activities, which I'm sure they're gonna have a lot of pain with, so you probably won't have to tell them twice or anything like that. But most importantly, depending on how the surgery went and if there are any complications, they're gonna have a weight-bearing status. Most of them are gonna be full weight-bearing, but you might have some that are partial, and if someone has a hard time understanding what that means, you have to train them to know, okay, you're only toe touch or you're only 50%, and you have to give them a representation of what that's like so they don't go home and put too much weight on that new replacement. And then of course monitoring for infection signs. One of the biggest things is you just don't want them to be doing any sort of twisting or pivoting on that surgical leg, just to really decrease the risk of having major complications.
Okay, so as Seth mentioned earlier, this is just a surgery that is going to replace the damaged ends of both the femur and the tibia. So there is going to be an incision made on the anterior aspect of the knee joint, and that's just to expose the damaged tissue. From there, they're going to move the kneecap to the side just to be able to see behind the kneecap to see if there's any damaged tissue behind there, as well as exposing the damaged tissue on the femur and tibia. So after the damaged portions of the tissue are removed, then they will place the implants. Like Seth said earlier, these are going to be metal implants placed at the ends and top of the bones. There's also a plastic spacer placed in the middle, and that's just for the joint to be able to move with a reduction of friction and also absorb different forces just as the meniscus would. So after all of the parts of the implant are placed in, then the kneecap is sealed back up, and then there's a bandage placed around it. So on the next, at the bottom of this slide, there is a link for a video, but we're gonna show one on the next slide.
The knee consists of tibia, shin bone, femur or thigh bone, and patella or kneecap. In knee arthritis, the cartilage on the end of the bones slowly wears away, causing pain and irritation, making daily activities difficult. Arthritis can affect all or just one area of the knee. In this case, the entire knee is affected and a total knee replacement is performed. During the surgery, your doctor uses a series of guides to help remove the damaged bone and prepare the femur, ensuring proper implant size and alignment. Next, your doctor will prepare the tibia using a series of guides to ensure proper implant size and alignment. The final tibia preparation is completed and a trial spacer is used to confirm knee stability. Next, your doctor prepares the patella to accept the implant. A trial implant is placed on the patella, and the knee is checked for proper implant size and stability. The trial implants are then removed, and the surfaces are prepared for placement of the final implants. Your doctor applies bone cement on the backs of the tibia, femur, and patella implants for final fixation. This completes total knee replacement.
Alright, so after the procedure is done, we're going to go into the rehab process. So the maximum protection phase, which is weeks 1 through 4, and that is regarding or in reference to our Eric's book. The goals here are going to be control swelling and reduce the pain, achieve pain-free range of motion, and as stated earlier, the patient may not be able to get their full or their entire range of motion back in the joint, but we do want to progress to get as much as the knee will let us. We want to strengthen the quadriceps. The goal here would be to get them to about a 3 out of 5 MMT. We want to make sure that they can at least go through the range of motion with gravity or with some type of resistance. We want to help them if they come to us with a assistive device. We want to, throughout this phase, we want to make sure that we help them get rid of that assistive device. So we're going to ambulate with it, but the goal is to have it gone by the end of this phase, as well as patient education. So just educating them on different positioning, home education plans, things like that, to make sure that they are taking care of their replacement as well as progressing throughout the rehab process. I'm not going to read all of the interventions because I'm pretty sure we've seen all of these before, but each patient is going to present differently. So here's just an outline of things that you could use with your patient. It just depends on where they are, how their body's reacting to the surgery and things like that. But we will start them off on the stationary bike just to kind of improve blood flow and range of motion. We're going to do joint mobilization, specifically 1 and 2, because we know that those get rid of, or those have neuromuscular or they get neurophysiological effects. So we're going to we can either do it at the patellofemoral joint, tibiofemoral joint, wherever we see that the patient is benefiting from these modes, we're going to do them there. We're also going to go through calf stretches and different strengthening exercises throughout the whole lower kinetic chain, just to make sure that the patient isn't coming up with or to make sure there is no neuromuscular imbalances. We know that when we have surgeries, sometimes we're going to have weaker muscles where we had the surgery, so we want to make sure that other parts of the body are not overcompensating for that. So the next phase we're going to move into is the moderate protection phase, weeks 4 through 8. Here we're still focusing on reducing swelling, improving range of motion. As I stated before, we want to be full weight bearing without an assistive device, continue to improve the strength of the quadriceps, and also improve the neuromuscular balance and functional mobility. So we'll still stick with some of the interventions that we have from the maximum protection phase, like the stationary bike, but we'll move on to more interventions that will help with strength. So we can do some mini squats, we can do step ups and step downs, leg press, the 4-way hip with resistance bands, glute bridges, ball squeezes, just making sure that we're moving or we're strengthening all muscles of the lower kinetic chain to make sure that the knee can function properly. And then in the minimum protection phase, weeks 8 and beyond, the goal is here to improve cardiopulmonary endurance and aerobic fitness, continue to enhance proprioception, strength, and endurance, and return them to their ADL. So the interventions here are going to look different depending on the patient and depending on what they are trying to get back to. But we can implement some strengthening exercises like increasing the load on the leg press, introducing walking to help with endurance, but also helping with muscular endurance by adding dumbbells and just doing different positions, going in different positions. We'll also focus on improving proprioception and balance by doing some single leg stands on the foam pad. So on this side, we just have a physical or photograph of the different, interventions that we listed on the previous slide.
I was also gonna add, whenever you're providing, because a lot of these are gonna be most likely home exercise sheets, and they're gonna ask like, how am I gonna do this at home if I don't have this specific ball or this specific roll or something like that? Just have some alternatives, like off the top of your head, just to give somebody like that, if they're gonna do a short arc quad, then just wrap a 2 liter in a towel or something. That's a good spot to put your knee under, something like that, because they're always gonna ask, well, I don't have this at home.
Oh, I also forgot, so of course we want to work on, we want to still implement the Rice method, so we're gonna have, ice, we're gonna have them rest, we're gonna have them elevated and compression, just to, try to reduce that swelling, and the patients can also benefit from E-stim, so whether it's NMES, FES, or, things like that, that can still help with that muscle activation and to relieve pain. So for the overview, hopefully the students learned about the TKA, which is a surgical procedure used to replace the damaged knee joint with an artificial implant. We will discuss the indications for TKA, including severe arthritis, osteoarthritis, rheumatoid arthritis, failure of conservative treatment, and or just severe knee pain and disability. Students learn the indications, precautions, and contraindications associated with the surgery. The surgical procedure was explained, and students learn interventions and goals for each phase of rehab, focusing on improving pain management, range of motion, strengthening, and functional mobility exercises. These are our references, and that is the end. Any questions?
Did you find any, interventions that may have increased, outcome from the procedures, like pre-intervention?
The interventions, no, the biggest thing, in the pre-phase is just to make sure that we continue to have blood flow. We don't want them just sitting up, and building in any blood clots or anything like that, and just keep them moving. So anything that's working on range of motion is gonna be beneficial to them in that pre-op phase.
And also from Dutton, the biggest factor is someone's rehab after is the amount of muscle and the amount of contraction they get before the surgery, because they were saying up to about 6 weeks, most patients only regain about 40% of their quad contraction after surgery. So obviously if that original number is bigger, then that 40% is gonna be more functional for them.
This is a question for both of you. I don't know if you would know the answer for that, but is there a particular reason why they keep the patella bone and not just like replace it with other equipment too? Because it just seems like it's floating in space, almost like, I don't know, just there. Y'all know?
I would assume they're trying to minimize the amount of artificial implants and tissues put in your body just to avoid rejection from your body. I wouldn't think that there's a great reason why they couldn't just replace the whole patella, but why waste it if it's already kind of vascularized and has, tissue in it.
I like that answer.
Yes.
Did y'all find any research or literature about hemophilia being a contraindication?
That didn't pop up when I was going through it.
I see you have joint mobilizations, grades 1 and 2 in your interventions. So what joint mobilizations would you all perform?
So at the patella femoral joint, you can do superior glide, inferior glide, or medial lateral. That'll help with all motions of the knee. And then at the tibial femoral joint, you can do anterior glide of the tibia on the femur just to help it get that full extension, or you can do a posterior glide of the tibia on the femur just to help with that flexion range of motion.
Would you do anything at the tibial femoral joint?
Yes, anterior, posterior glide, just depending on what movement you're trying to achieve.
And then if we were trying to max out the extension, I would also add in some external rotation for the joint move as well, or internal rotation if I'm trying to get that unlocking motion for the knee.
Okay. Explain genu recurvature to me.
So that's a hyperextension of the knee. It's when you're at a standing posture and you've got around 10 degrees of hyperextension. And you wouldn't want that in a knee replacement because that's gonna kind of go outside the bounds of that artificial replacement, and it's gonna cause a very high risk of posterior dislocation.
I see in your intervention you have calf stretch. Why would you stretch the calf?
Just because the calf also crosses the knee joint, and we want to make sure that all the muscles that play a part in knee range of motion they have the most extensibility that they can, because we know if they're tight, they can restrict the range of motion.
How does the calf muscle, work or function at the knee joint?
So it is involved in flexion of the knee, because it's posterior to the knee joint. So a tight calf muscle may limit the extension that a knee is able to get.
That is very good. Very good. You have to know that. I'm so glad you answered that question like that, because often we neglect stretching the calf muscle when someone has a total knee joint replacement. And you have to stretch it, and I work on it manually as well, but that is the reason why you have to work on it. It's straight from the textbook, straight from knowing muscle action and muscle function. Good job.